I'm here to talk a little bit about some of the prescription medical management considerations around clinical care as it pertains to traditional Indigenous medicines. And I'm going to make a few notes on the importance of the pluralistic use of the term going forward. Now, it's important as Indigenous people when we're doing any sort of introduction or talk to always root ourselves in the locations and geography and the lands of where we come from as a part of an act of responsibility and reciprocity to our ancestors, past, present, and future. I'm originally from the subarctic area of Canada. The Western Way is called the Northwest Territories. I'm a member of the Deninukwaya First Nation, which is from the territory of Dene, which is the land of the people. The Dene peoples stretch over a large geographic area all the way from Alaska into Yukon Northwest Territories, the northern part of many of the southern provinces in Canada, but we're actually also distally related to the Dene people in the southern US. They were the smarter ones that kept going to the warmer weather. We were the ones that stayed up and continue to have the cold as a part of our lifestyle. So my family is rooted directly within there, although in the last few years I've been located at the University of North Dakota here in Grand Forks. Now, a few notes of consideration. It's always important to ground ourselves in terminologies when we're discussing Indigenous concepts. There's a lot of debate, in terms of terminology and how it's utilized within various settings. And it can be quite confusing sometimes, frankly, to those that are new to spaces and just learning about the appropriate terminologies that are warranted in various settings. And Indigenous peoples is the most common worldwide as a designation of Indigenous peoples. However, there are many peoples that do not identify themselves as Indigenous peoples, considering it too pan-Indigenous, meaning that it homogenizes the appearance and cultures of Indigenous people, preferring to use their own specific tribal names. However, many international organizations for ease continue to use Indigenous peoples, noticing that I've capitalized both Indigenous and peoples as proper use of the terminology. Here in the United States, American Indian, Alaskan Native is most commonly used. Native American is inclusive of Pacific Islanders. And then in many other countries of the world, you'll sometimes see First Nations people identified. In the Canadian context, First Nation is used quite often in addition to Indigenous people, as well as Métis and Inuit people. Aboriginal is terminology that's still used quite often in Australia as it pertains to Aboriginal peoples of Australia. And then, of course, as noted, the specific tribal identity names are also still commonly used and probably the most widely appreciated. So when I get asked what's the best word to use to describe Indigenous people, my answer always is whatever the Indigenous people that you're working with prefer to call themselves. So it's really, something that's important to acknowledge and know in the areas that you do your work is what is the most appropriate use as recognized by the local communities within your area. Now, because we're talking about traditional Indigenous medicine today, and I do specify traditional Indigenous medicine quite often comparatively to just saying traditional medicine. And the reason for this is because there's very large traditional medicine systems around the world that have been utilized, such as traditional Chinese medicine, Ayurvedic medicine from India, which of course is another form of traditional medicine, Kampo. There's a number of them. However, there is differences between those traditional medicines and some of the traditional Indigenous medicines that actually exist even within those countries, which sometimes are referred to in those locations as forest medicines or other types of practices that embody most often a spiritual aspect to it. Now, when we talk about the people that practice, steward, or oversee traditional medicine practices, the names will vary in English, and I specify that very clearly, that these are English adaptations of names and do not do justice to many of the traditional Indigenous language names as reference to the people in their community that hold this type of knowledge. Traditional healers are commonly seen, medicine people, traditionalists, even just elders. Some communities use shaman, however, that word is often applied incorrectly in some American Indian and Canadian Indigenous contexts, although Inuit people, for example, still use the word shaman in the English language sense, as well as some groups within Latin America. And then, of course, most commonly is the Indigenous language specific name. The definition within my community in the traditional language translates directly to person who uplifts the people. That's actually the translation of what we would call a traditional healer, person who uplifts the people. And many of our Indigenous languages are verb-based. They're not noun-based, so they're always in action. And this embodies that very clearly on the purpose of a traditional healer within a respective community, and specifically here within my community. And although communities often know the elders or knowledge holders who hold this type of knowledge and steward this kind of knowledge, traditional healers seldom refer to themselves as healers or medicine people. In fact, in many communities, it's considered to be frowned upon to identify yourself as somebody with special gifts. We are very humble people as Indigenous people, and that sometimes can bring negative attention to the person because it brings ego into the equation, according to many cultural and traditional protocols. Now, again, to avoid pan-Indigenous connotations, meaning perspectives of traditional medicine that are looked on to be the same across many tribal groups, is just false. However, most often in many cultures around the world, traditional healers were specifically chosen and mentored into adulthood, and they often held many roles in communities, including that of a politician, medicine person, but also a counselor. There's often thoughts that talking about traditional medicine gifts or knowledges may actually weaken, and that's that relationship to ego being frowned upon and remaining humble in the work, because as a leader, you were expected to be humble in service to your people and to the creators, to the spiritual realm, pending the belief system of the Indigenous people's community group. There was many factors that affected traditional medicine as it is practiced today within many communities worldwide. Speaking of pandemics, of course, Indigenous people were very much affected by the last pandemic in 1918, including my great-grandparents, who both perished from the Spanish flu up in the Canadian subarctic with very little immunity to flu viruses in general. Many of our medicine people and knowledge holders were wiped out during that epidemic, which caused a huge void in the knowledge around traditional medicine. And this is not exclusive, unfortunately, to my community. Here in the United States, we call them boarding schools. In Canada, they're called residential schools, which had another huge impact on the passing on of traditional medicine knowledge within communities, as Indigenous children were often taken from their family for the purposes of killing the Indian and saving the man, with a suppression of all cultural expression, including the outright banning of ceremonial and traditional practices. So many of the practices went underground, and many children did not or were not able to learn some of this important aspect of their culture due to these historical and events and their ongoing effects today. And the other piece that occurred in regards to the boarding schools is that there was a lot of shame of being Indigenous, and this was ingrained within the schooling system. And I love this quote because I think it really, sums up the important lessons learned of how we move forward. And speaking from an Indigenous woman within the Canadian context, we have something to offer the world. Biggest challenge is to not believe what we were taught about ourselves. A huge legacy that continues today as a result of these historical events. Now, switching over to traditional medicine, and again, these are generalities that lose the essence and the nuances of some of the individual tribal practices, which can vary. However, some of these have a lot of common elements that go between them. And when we think about the etiology of illness or the root of illness from a traditional medicine perspective, oftentimes the root of an illness may have or is seen to have its source in any one or a combination of spiritual, physical, emotional, or mental quadrants of life. Many people may have heard of the medicine wheel, which often has or depicts these 4 quadrants of wellness, although it's important to note that many Indigenous peoples do not use the medicine wheel as part of their cultural symbolism and practice. Also, in some cases, etiology is considered to be a blockage within the body, preventing growth or movement forward in life because a learning process is not occurring. Somebody's stuck within some sort of realm of the way that they're being in the world. Illness is often seen to be or have a connection to a spiritual process that is in need of being communicated with. So because of that, the root cause is often sought to be treated and not necessarily just in support of symptoms. So this idea of supporting instead of countering the body. And then the creator or this spiritual element is often invoked ancestors as well as part of the gift-giving process, both for healers themselves, but also for the medicines that are used as a part of the practice. There's many different types of medicines and entry points that are used. Smudging is more well known, with some of the plants being burned for specific ceremonial purposes or medicinal purposes. For the purpose of introduction through inhalation, drinking or ingestion. A lot of people are surprised to know that there's a form of acupuncture that existed in the Americas as a part of traditional medicine. It was not exclusive to the Asian countries. It's most often talked of as cutting or subcutaneous types of treatments, most often using bones. Blowing, suction actions, chewing using powdered agents or other agents or ceremonial tools, and of course used in any combination depending on the traditional protocols that are invoked within a respective community or condition. There's a great mindfulness of seasonal timeframes for gathering and storage. In fact, there's some medicines that are completely toxic at one time of year, but are completely safe at another time of year. And the amount of and depth of knowledge of these plants and the appropriate times to pick are really quite incredible. And also noting, of course, the important change in nutrients that occur within plant-based materials throughout the seasons and the knowledge of them that innately in regards to the best time for picking certain elements. Barks, root, leaves, herbs, flowers, stems, berries, and animal products, including things like feathers, etc., can be used as a part of medicinal practice. There's always an aspect of respect, reciprocity, ceremony, offerings. Traditional medicines are not something that's separate from ourselves. In many Indigenous worldviews, they're a part of us because we are nature. We're considered from the land, in which case there is a need to see many of these medicines as our helpers, as our relatives, and therefore we need to treat them with great respect. And then, of course, food is eaten as medicine. And even the animals themselves ate the medicine plants, and then the people ate the animals. So there's this hierarchy of support systems that are invoked, pending, of course, the traditional foods that are eaten within a respective area, because some Indigenous communities relied more on animal products and many relied more on plant-based products and ate very little meats as a part of the diet. In terms of some of the ceremonies that are often used, sweat lodges are fairly well known, however, probably not in the sense of the depth that they're actually used within communities. Fasting ceremonies are very common and becoming, thankfully, revitalized in many communities, both for the purposes of connecting with land and ceremony, but also for the purposes of gaining a path in life, prayers, smudging, singing, drumming, and the importance of following traditional protocols, which are protocols that often come from innate, what we call natural or first laws that exist within a land. And many of these have spiritual connections, but also have strict do's and don'ts, so to speak, pending, of course, the ceremony and the peoples and even the person that's running them, pending their gender, pending their background, and pending the agents that they might be using as a part of the ceremonies. The most important thing when it comes to traditional medicine, and I cannot highlight this enough because this is an issue when people grab things like a medicine wheel, for example, and assume that it is all Indigenous peoples within the North American context that use a medicine wheel, which of course is not the case, is that there's incredibly diverse practices. So within the broad scope of traditional Indigenous medicine, each tribe has its own belief systems, its own ceremonies, practices, and traditional medicines they may use. Yes, there may be some overlap in terms of the underlying worldview, the underlying application of certain elements. However, we do need to be very cautious about invoking any pan-Indigenous, broad, homogenizing aspects of Indigenous traditional medicine practices, because we do lose the essence and the nuance and the importance of that diversity that exists within all of the regions here in the United States and abroad. Now, I wanted to highlight one specific study that we worked on recently with an elder. It was a scoping review that was done on traditional Indigenous medicine in North America. And one of the reasons for this was the lack of available information for clinical providers, for counselors, for social workers in learning about some of the aspects of traditional medicine as it's applied to bridging or partnerships with Indigenous community projects or even with Indigenous traditional healers. And the scoping review itself has an attachment, an S2 file at the bottom. It's free open access, which holds 249 names of academic journal articles that have been published on the topic since the beginning of time. And we noted that there was 5 key categories of articles that had been published. The first was just very general aspects of traditional medicine. There was many articles that fit into the category of integration of traditional and Western medicine systems, one that was more focused on ceremonial practices for healing. There was a bunch on usage or rates of traditional medicine use in respective communities that were looked at, and then traditional healer perspectives as well. And we saw great trends in regards to the articles that were published. They were increasing amounts as time went on, which was a positive element. However, we did notice a lot of variability in regards to the articles that were out there. One of the biggest challenges being is that especially for older articles, but even for some new ones as well, that much of the writing around traditional medicine was done by non-Indigenous academics or clinicians or researchers, which often gave more of an anthropogenic or anthropological field. Sorry, I was doing a paper on climate change this morning, so thinking of different subjects here. Anthropological perspectives, outsider views of these types of practices, which often were, frankly, in some cases, completely inaccurate, or did not capture the important elements of traditional medicine practices may have been defined or described by communities itself. And there's reasons for this trend. For any folks that are working in healthcare or research, we are very clear that there's a long history of mistrust of medical systems, which are very warranted. My relatives, their first experience of Western medical care was in those boarding schools that we had learned about before. So you can imagine in a place where you faced physical abuse, sexual abuse, and your culture was beaten out of you, that your experience of medicine within that time frame can very much skew your view of what healthcare is all about. And then, of course, those survivors, those boarding school survivors, had children who listened and heard those views on healthcare, and then they had children and had experiences of racism, structural or otherwise, and other ill effects that they pertain from their misunderstandings and experiences that have created harm within healthcare. So there's a hard and very much a difficult process in trying to have communities share these types of topics and information openly, especially with researchers in the area of traditional Indigenous medicine. Now, I wanted to just highlight a few pieces here because I think they help to build up some of the concepts and the applications that we're going to talk about clinically shortly. And there are a number of studies people are often surprised to hear on traditional medicine's use in various capacities. There was a mixed method study, for example, done by Maingai and colleagues in 2013 that found that the level of spiritual transformation achieved through interaction with traditional healers was associated with a subsequent improvement in medical illness in a majority of the people, 134 of the 155 that were part of this particular study. And that, interestingly, the association exhibited a dose-response relationship, which is not a surprise to me, but an important piece to start improving the understanding of the impacts of this type of approach. In a 13-week intervention with Indigenous healing and seeking safety, there was 17 participants demonstrating improvements in trauma symptoms, specifically as measured by a standardized tool with a significant mean decrease, representing a 55% improvement from their original baseline. Now, when it comes to the use of traditional medicine, how many of our Indigenous people are still using traditional medicine? And since the dawn of publication history, I think the earliest article in there was 1898. There have been a total of 14 published articles in the entire literature denoting usage of traditional medicine amongst people. And these 14 articles included over 5,000 participants who completed either surveys or interviews. They were only in certain geographic areas. Many of them and most of them were published prior to 2009, in fact, 80%, so quite old in terms of the data. And the rates of usage of both traditional medicine and traditional healers varied quite a bit per region, at least in regards to the 14 studies that were published here. Now, this slide is very small. I apologize about that, but I do want to highlight a few key pieces here because this is a summary of the studies that were done in regards to usage rates of traditional medicine. There's communities here represented both from the United States as well as Canada. And a few notable points here that came up that I want to just read out. In one study from 2014, 90% of individuals interviewed endorsed inclusion of traditional health practices into their medical care. In another study from Milwaukee, more than a third of the patients seeing healers received different advice from their physicians and healers. The patients rate their healer's advice higher than their physician's advice 61.4% of the time, and only 14.8% of the patients seeing healers tell their physician about their use. And I want to repeat this. Only 14.8% of the patients seeing healers tell their physician about their use. And this is not a surprising statistic to me at all. In fact, we'll see this repeated in some other areas. 92.4% of respondents in another study had not discussed this with their physician. Again, another study, 92.4% of these respondents had not discussed their traditional medicine use with their physician. Another study, of those who did not use traditional healing practices, 51% reported that they would actually like to use them. Another study, nearly half of the sample had used traditional services. So again, a few key points of note here. Overarch, at least with the small amount of studies, definitely positive viewpoints of traditional medicine, but a key point which comes to clinical impacts is the lack of desire or action of many people using traditional medicine to share that information with their physician or care provider. There were 18 studies that elucidated perspectives from elders and traditional healers, ranging in dates from 93 to 2019. Interestingly enough, the majority of the traditional medicine articles, not only in this category, but just generally, were published in either nursing or mental health related journals. There was very little in terms of actual medical journals or in other fields. Many were based in the US. In fact, probably a majority of the studies were in certain categories. And what's important to me, especially when it comes to looking at research in regards to traditional healer perspectives, and it's not culturally acceptable for me to alter the words of traditional healers. That's not my role. So as a result of that, when it comes to looking at some of the statements, I wanted to add in a few specific notes that some of the healers had shared in a beautiful article that was done by an Indigenous researcher. And one elder had said that the doctors and nurses at a local hospital asked me to speak to them on natural medicines. So I did. You could tell the doctors have a hard time trying to understand traditional healing and the use of plants to heal. It's hard for them to understand. Some of them got up and left when I started to talk about how you have to develop a relationship with the plant world. They sometimes have a hard time if things are not done their way. I respect the medicine. I just wish Western medical persons would understand. Another quote, when we gather medicine, the plant has a spirit in it, and the spirit of those plants stays in the medicine. Every individual is different. Every remedy is different because specific things work for specific people. We're made up of 4 parts, physical, mental, emotional, and spiritual. Sometimes sickness can be caused by imbalance within a person. When we do Indian healing, it goes to the source of the problem, not to the symptoms. So we can see some of the notes of the things that we've heard about previously on the sides of the importance of holism, the importance of going to root cause of issues and not necessarily only looking at symptomatic elements within somebody's well-being, but also this, lack of understanding in some cases of in between traditional healers and Western medical providers, and some of the potential consequences being some of the statistics we saw on the previous slide, where there is a lack of a sharing of this information, again, with healthcare providers. So the question always comes in is, when we talk about traditional medicine and conventional medicine or Western medicine, do we talk about the potential for integration? Do we talk about the potential for bridging? Do we talk about the potential for partnerships? And each of these words has a lot of baggage. I very much oppose utilizing inadvertently the word integration, because it makes the assumption that integration is even possible. However, when you have complete polar philosophies of treatment that are rooted in completely different worldviews and purposes and objectives, it makes it very difficult to look at integrating these types of practices together. However, there is the opportunity for potential bridging and partnership, depending on the openness of respective communities, because it is their choice ultimately whether or not they want to look towards these models. But clearly with a foundation of respect needed as a part of that work. Mention, of course, about the differing worldviews that makes integration difficult. And there is a definite fear of knowledge being lost, fear of traditional Indigenous knowledge as it pertains to medicine being lost. Yet again, this hesitation to share, there's been lots of unfortunate mistrust events, including things like exploitation, importance of protocol and respect. I know some elders that are concerned about medicines being used and turned into drugs and used for profit-based, where money has no place within traditional Indigenous medicine practices culturally. In fact, money is not valued. It's not only not valued, it's looked at sometimes as a contamination of the entire experience, that it brings in another element that can actually affect the efficacy of the treatment and the ceremony that somebody's engaging with. So we have these head-butting events of evidence-based medicine, which of course we know is the gold standards. as it pertains to clinical practice, as it pertains to prescriptions, as it pertains to programs and interventions, which follow a Western scientific process and protocol with very defined and clear elements as part of that. And then we have evidence informed, which is more around the area of traditional medicine, which is the informing of or this empirical process through thousands of years of experience of trial and error, of ceremonial engagement and practice, informing the evidence of use, the evidence of current use of some of these specific agents within various health conditions. So this distinction is important. Of course, evidence-informed ways of knowing is often orally transmitted as opposed to written down, but there is value and benefit in there, because when I always explain about evidence-based processes, it's evidence-based for who? We know very clearly that Indigenous people are most often and have not been included in drug trials, in medical trials to any sufficient extent, yet we assume that those medicines work in the same way in our people. We also assume that the programs and interventions that are developed in an evidence-based way in non-Indigenous programs can automatically be aligned with Indigenous peoples, which again, we know is not the case. The evidence for that is the clear health disparities that we continue to see amongst Indigenous people, because the way that we've been doing things, the way that we have been applying Western models of healthcare and treatment to Indigenous people do not work. So there's been a number of great programs that have sought to look at integration. And I use the word here integration because oftentimes in the studies, this term was identified. However, I don't think in many cases there was a consideration for the importance and the symbolism of that word. Again, looking more towards bridging and partnership in my mind. There was actually 61 articles identified in this specific category. They ranged all over the place in terms of years. However, they did tend to trend more recently, which means there seems to be a movement and look towards the possibility of actioning this and doing this, and a range of topics were identified. There's been movement even within residency programs. In 2011, the University of New Mexico Public Health Department and their general preventative medicine residency program started to integrate traditional healing into the resident training curriculum, with full implementation completed by 2015. So, as a part of that, we've seen many models, including the NUCA model in Alaska, which has done a great job of this. There's a number of hospitals, IHS hospitals even, but also a lot of the tribal-run health facilities that are starting to look at this partnership. Anishinaabe Health Toronto is a clinic within downtown Toronto in Canada, which has its traditional healers on par with its doctors and physicians within the facility. In fact, they've actually developed and defined Indigenous diagnoses to be inputted in the electronic medical system so that they can actually collect data on patients that are seeing both providers utilizing Indigenous diagnostic codes as well. We've seen this also occur in Nicaragua, where they've actually developed national tracking on indigenously defined illnesses as a part of their tracking for disease processes. So there's this need for advocacy and awareness building on traditional ways of healing, really emphasized throughout this whole bunch of articles. One quote by Gong in 2016, Lakota doctoring traditional healing remains highly relevant for wellness interventions and healthcare services, even though it is not amendable in principle to scientific evaluation. So some implications and recommendations. Self-determination is an important word for communities, which embodies sovereignty. It embodies being able to define our own way of being and our own way of accessing wellness for our people. And self-determined options for traditional Indigenous healing are still, however, very much lacking in Western institutions, yet access is really a treaty right for Indigenous people in this nation, as well as in other nations that have treaties defined There is a need for more open spaces for dialogue and consequent action surrounding the use of Indigenous traditional healing, often desired in racially diverse medical settings, and prioritizing engagement with Indigenous scholars and other scholarship community members and local knowledge holders is absolutely encouraged. And the reason why is because a number of the published articles out there, including the ones in this review as noted, were often done by non-Indigenous peoples. So in some cases, it's hard to know what's appropriate and accurate within the own tribal community's words, and hence the importance of engagement locally, given the nuances and the distinctions in the essence of practices and traditional protocols that are in various areas of the United States and abroad. Now, there's some legal issues that come into that. Harvesting, of course, a lot of our public lands are no longer public. So Indigenous lands have often been taken away, and many live on unceded territories. There's continual relocation pending climate change issues, but also, of course, historical relocation of communities outside of their traditional homelands. And these create problems for being able to gather specific medicines that only grow within certain areas. There's tobacco laws, often even in hospitals, for example, about how to be able to carry out smudging protocols. There's thankfully been a number of hospitals leading the way in being able to ensure accessible access to smudging within hospital settings. Carrying medicine bags can often be an issue. Bags are often carried as part of protection for many Indigenous communities. However, they often show up on airline scanners, for example, but they're not able to be touched by anyone, but they often get touched when you go through the scanner and something shows up. And then this issue of licensure, which has been a big debate, because when we talk about licensure, we're talking about a very colonial way of thinking about classifying somebody as being a traditional healer or not, comparatively to the own community and the own people defining who in themselves is appropriate for that role within the community. As noted, lots of mistrust of medical system, and I'll address some of the concepts around that as it pertains to cultural safety. And then generally, people do want to work together with respect, and this idea of medical pluralism comes up, which I'll broach here shortly. Now, I wanted to bring up cultural safety, noting that it does have varying interpretations within and between countries. Cultural competency is very different than cultural safety. And for those that have taken cultural competency training or otherwise, perhaps you'll note the distinction here. But cultural safety foregrounds power differentials within society, the requirement for health professionals to reflect on interpersonal power differences, their own and that of the patient, and how the transfer of power within multiple contexts can facilitate appropriate care for Indigenous peoples and arguably for all. It was originally described as a focus for the delivery of quality care through changes in thinking about power relationships and patients' rights. So this is the difference between learning and being educated about the cultural practices within a region comparatively to a self-reflection process of power and how that plays out within the medical environment. Two very, very different things, because instead of learning about the other, it really is learning about oneself and the aspects of bias that may pertain, but also, again, the implications of power for the engagement with patients, and in this case, of course, with Indigenous peoples. Now, in contrast to cultural competency, the focus of cultural safety, as noted, moves to the culture of the clinician or the clinical environment rather than the culture of the exotic other patient, where the movement from cultural competency to cultural safety is not merely another step on a linear continuum, but rather a more dramatic change of approach. And this conceptualization of cultural safety represents a more radical, politicized understanding of cultural consideration, effectively rejecting the more limited cultural competent approach for one based not on knowledge, but rather on power. And there's a huge body of literature developing around this, and many of it rooted within the Indigenous peoples context, coming out originally from Aotearoa in New Zealand, but also spreading from there. It's been very well uptaked in Canada and slowly beginning its understanding within the US context. Now, medical pluralism as another definition is important to understand. And medical pluralism refers to the coexistence of differing medical traditions and practices grounded in divergent epistemological positions and based on distinctive worldviews. So divergent epistemological positions basically means that there's different ways, different theories of how we apply knowledge within the world. And our distinctive worldviews, of course, very much impact how the practice of medicine occurs. But medical pluralism really acknowledges this ability of coexistence. It's the employment or use of more than one medical systems. But it's also important to note that it is commonly embodied by Indigenous peoples, especially elders, where many of our people still will access healthcare to some extent, access emergency services when needed. But they will often also utilize other forms of treatments or well-being. So medical pluralism, again, commonly embodied by Indigenous peoples, and is the employment or use of one or more systems of medicine. And there's actually been a recognition of medical pluralism as being able to help clinicians ethically debate relatedness to CAM, or complementary and alternative medicine practices. There's an importance of acknowledging the health beliefs and practices of patients and accommodating diverse healing practices. And construed as such, the recognition of medical pluralism actually encourages pragmatic willingness to examine the personal and cultural meaning associated with complementary and alternative medicine use in this case, although I'm applying it in the context of Indigenous medicines, the bias and assumptions often prevalent in biomedicine, as well as the risk-benefit ratio of CAM practices. And in this way, recognition of medical pluralism can help clinicians enhance patient care in a manner consistent with basic ethical principles. Now, shared medical decision-making offers potentially a helpful framework for applying the ethical obligations of primary care clinicians or other healthcare providers articulated in the previous slides' principles of biomedical ethics. And I often look to shared decision-making as a great tool to utilize within cross-cultural contexts of medical practice or pharmacy or otherwise. And it's really an approach where clinicians and patients share the best available evidence when faced with tasks of making decisions, and where patients are supported to consider options to achieve their informed preferences. Now, the process in which both the patient and physician are said to contribute to the medical decision-making process, whether or not it's tests, whether or not it's treatments, whether or not it's care plans. And you'll note here that shared decision-making emphasizes equalizing power between patients and healthcare providers to create more equitable healthcare. So there's that word power. So you can see the connections here between the definitional application of cultural safety and that of shared decision-making, this ability to equalize power between patients and healthcare providers to create more equitable healthcare, where healthcare providers are able to work with patients to ensure that they have informed preferences and can make a choice on their own for the treatment that they desire to have. And I remind, of course, back to this slide that we covered before on usage about how there's such a high rate of Indigenous peoples who are not comfortable sharing their traditional medicine use within their physicians or within their clinical environments. And my thought process that I'm fairly confident about is that if we had more shared decision-making models rooted within cultural safety principles and practice in healthcare widely, that we would have more comfortableness opening these discussions within medical environments, because it does not mean that the clinical provider needs to be an expert within traditional medicine. What they need to be an expert in is being able to communicate and help patients come to the preferences that they choose as a part of their treatment. There's many contexts surrounding shared decision-making, of course, demographics, language barriers, idea of respect, cultural perception of worldview acceptance, pinning the provider's communication patterns or symbolisms with patients. And then, of course, trust and anxiety, which is a place. There's a great article by Groot and colleagues in 2019 that goes into some of these aspects very, very well from a theoretical perspective, and highly recommend it for those interested in this area. And ultimately, fostering Indigenous worldviews includes culturally appropriate services to mitigate the negative impact of the macro context. So this idea of mistrust that I talked about, cultural discrimination and systemic and historical abuse. And we know when healthcare providers accept and include Indigenous worldviews into the decision-making process, trust is often better facilitated and patient anxiety is often reduced. Indigenous patient engagement in shared decision-making may rely on healthcare providers and healthcare systems' ability to integrate multiple worldviews. So again, back to this idea of medical pluralism. So some clinical considerations here to finish off. Many health professionals may not know if the patient they are treating actually identifies with a tribe or how traditional he or she may be. There's many Indigenous peoples that do not choose to use traditional medicines, and that's their rightful choice. So it's important to understand how your patient self-identifies and how that may affect their belief system around healthcare practices. There's an important need for translators fluent in Indigenous languages, especially as it pertains to our elders. There can be a lot of miscommunications that happen within these environments and in my mind lead to and potentially breed greater risk of error. Clarifying patient communications by restating and asking, do not assume. It's always good practice to take that extra time, especially with our elders, to make sure that they understand by being able to talk back some of the plan, just not making assumptions that they've understood your instructions. Respecting the historical experiences of elder patients. Some may have experienced boarding school experiences historically or have had close family that has, which could potentially cause strong emotional responses. I have a story about this in regards to elder who had went to a residential school. One of the reasons why she never got pap smear screens was because of the sexual abuse that occurred during the boarding school experiences, and nobody had investigated or considered those types of barriers to cancer screening due to the historical effects of some of these experiences. And then cultural taboos. In some traditional cultures, to speak of an illness may bring on the illness. So this, as you can imagine, caused some initial issues even in my area around COVID, because to talk about COVID would bring the illness to the community. So being able to understand some of these perspectives help with the public health response, help with clinical decision-making with patients, because you have a better idea about where they may be considering the pros and cons of making a decision as it pertains to a treatment. Many of the plant substances that may be used have traditional value, have evidence-informed value for healing or other purposes in communities. And although these substances have not been studied in depth using a Western scientific model, they have often thousands of years of historical use behind them. And you can imagine a community that's had thousands of years of historical use of building knowledge in an agent and has seen successful use in their community, that you have a white scientist or a clinician coming and saying your plant has no benefit, and how that contributes to the mistrust and the divide between Indigenous systems of wellness and medical care without a thought and consideration for the implications for that, which is most often patients not engaging with healthcare or just not telling their providers about the use, as we've seen within those previous statistics. Concerns about drug interactions with traditional medicines will vary, and it's important discussion to have with patients in the context of shared decision-making. So what that means is that the clinician can open up a conversation about the potential for interactions and working with the patient to identify pros and cons, with ultimately the decision resting with the patient. Interactions could in fact be complementary, such as when natural substances reduce the side effects or toxicity of medications. Interactions, of course, in some cases can be contraindicating, meaning, of course, as we know, the exposure to a substance should really be limited or avoided due to possible harmful effects. And the way that I look at it with this in terms of decision-making clinically, because, you know, there's very few plants, to be frank, that I'm really concerned about, because when you use it in a traditional indigenous way holistically, there's a much lower concentration of many of the chemical properties comparatively to the supplements or the agents that you buy in a pill on a shelf, which have been artificially artificially manufactured to increase the dose of some of the active ingredients, which is no longer than the traditional form of the plant. But when somebody's on a narrow therapeutic dose medication, such as blood thinners, warfarin, those types of things, that's where I get a little bit iffy sometimes with patients and really start to open up that conversation. Just because, again, there's a lot of unknowns with some of those agents, and we wouldn't want to have the patient have an adverse event. And maybe there's ways that we can work around it, whether or not it's starting off at very, very low doses, working with their traditional healers to see what a plan might be forward. Pure lack of knowledge on behalf of the provider towards traditional medicine often results in default concern that a drug interaction is likely. I'm sure everybody knows this is very much the case. If you're not sure, you're more likely to default to the negative, that it is an interaction and is possible. But this does not support shared decision-making model, and it contributes to the mistrust that exists within communities. If there are concerns with the potential for negative drug-plant interactions, providers really should involve patients again in this model, involve traditional knowledge holder if the patient is open, or a medicine person if the situation warrants and they're open to communicating in that way to ensure ultimate safety for patients. But of course, respecting the patient wishes for shared decision making. And I want to end with your response, your engagement with shared decision making, and the respect for usage of traditional medicines will determine whether or not the patients and clients that you work with will actually give you future elevations around that. If they've opened up to you, that's a huge success in and of itself. Take that, as a key sign of importance of partnership moving forward, and how you interact with them will determine how that relationship goes forward. So I always like to end with quotes from elders, because elders are the ones that guide us, root us within our communities, and are the knowledge base here. And two elders from my region, we're all trying to have healthy communities. We need to work together, traditional medicine and Western medicine. We need to talk, to respect, and to honor one another. We like the idea of where the two rivers meet. Traditional medicine and Western medicine can run parallel.